everyone. So welcome everyone to this pharmacy workshop session where we are going to be discussing innovations in CF pharmacotherapy. I don't think there's anything specific about buttons, but we are going to learn about a variety of things and hopefully learn what different innovations are happening. My name is Lori Chen, and my co-moderator is Stephanie Dillmeyer. She is a clinical pharmacy specialist in pulmonary medicine at Children's Mercy Hospital in Kansas City, Missouri. She also serves as an adjunct clinical assistant professor at the University of Missouri, Kansas City School of Pharmacy in Kansas City, Missouri. She received her Doctor of Pharmacy degree from Drake University and completed a PGY1 pharmacy practice residency at Children's Mercy Hospital. She is a board-certified pediatric pharmacy specialist who has worked with pulmonary patients in the inpatient and outpatient ambulatory care settings for 8 years. Stephanie is a proud mom of 3 young kiddos, but she also finds joy in her free time through reading, music, and all things Taylor Swift.
And I'll take a minute to introduce Lori, but Lori Chen is a clinical pharmacist with the Ambulatory Cystic Fibrosis program at the Hospital for Sick Children, or Sick Kids, in Toronto, Canada. She also works as a clinical informatics pharmacist at Sick Kids as well. She's been working with the CF population in inpatient and outpatient capacities for over 12 years, and when she is not at home running after 2 energetic little boys, she enjoys dragon boating, which I don't know what that is, reading, singing, and trying to get some sleep. If you are curious about the session description or the educational objectives, those are in the app. But we are excited to welcome 5 different speakers during today's program. We will have each speaker come up and give their presentation, and then we're going to reserve the Q&A session for the very end. So please feel free to submit your questions as they come up as speakers are presenting at any time through the NACFC app, and we'll again address those at the dedicated Q&A session at the end. And if you see a question that you are also curious about, you can vote for it, so it brings it to the top, and that will make it easier for Lori and I to know what you guys are most curious about. And then for those who might need to leave early, this is a recorded session, so it should be available later for viewing.
So our first speaker is Dr. Blair Lennon, and she is a pulmonary and critical care physician. She serves as the co-director of the bronchiectasis program at the Intermountain Medical Center in Salt Lake City, Utah. She completed her internal medicine pediatrics residency at the University of Michigan, followed by a pulmonary and critical care fellowship at the University of Utah. Outside of her professional work, she enjoys trail running, camping, skiing, attending live music events, and participating in weekly bar trivia. She will be presenting a national survey that explores treatment gaps in type 2 inflammation and cystic fibrosis.
Thank you, everybody, for being here, and I'm very excited to present my and my team's research on this question about treatment gaps in the treatment of type 2 inflammation in people with cystic fibrosis. So just starting with a disclaimer. And then for my disclosure slide, I'm very grateful this research project is supported by a grant through the CF Foundation, but otherwise have no other disclosures. So for background, as many of us are aware, cystic fibrosis is a disease that affects multiple organ systems. 2 of those groups are the lungs and the sinuses. In fact, the CF registry shows that in adult patients, about 35% of our patients have asthma and 50% suffer from sinus disease. And it's actually higher in the pediatric population. And if you have sinus disease, asthma, or you care for people that have this in CF, you know that these diseases are associated with really high symptom burden. It's really frustrating. What's really interesting is when you have somebody that has asthma and sinus disease, this is often associated with a disease umbrella called type 2 inflammation. Specifically, T2 is part of our immune system that helps us address allergies. And when that immune response is upregulated, maladaptive, you have type 2 inflammation that presents with hard to control asthma and severe sinus disease. And while type 2 inflammation in CF remains a little bit controversial, there's a lot of good research in CF that supports that the CFTR mutation and other factors associated with CF actually promote higher rates of type 2 inflammatory cells and factors. So this is just a schematic example of this that shows how different parts of cystic fibrosis promote the type 2 inflammatory cascade. This actually becomes super important because we have excellent treatment modalities for type 2 inflammation, specifically a group of medication called biologics or asthma biologics. And these are injectable medications that are made of monoclonal antibodies that target specific parts of the type 2 inflammatory cascade to try to halt it. And this becomes really important because there's robust, excellent clinical trials on the use of these type 2 biologics, which exclude people with cystic fibrosis. And of the few studies we have using these medications in cystic fibrosis, the numbers are very small and not robust data on this. However, anecdotally, through our own practice and speaking with our colleagues, we know that people are using these medications in CF. And this creates a couple of issues. So, number one, these medications are very expensive. And while we hope that they would be helpful for people with CF, we don't actually know that. And so originally what we did, and we are still doing, is we gathered a group of collaborators from multiple centers around the country to create a study looking at outcomes in people with cystic fibrosis on biologics. And this is led by one of my mentors, Dr. G at University of Michigan. However, when we started to look into our study, we realized another really, really big issue. And that is we don't understand the landscape of the problem. Specifically, we don't know how often people are using this biologic in CF, and we don't know why. And if you've ever done a study, you know you have to know the background and the landscape of the issue to then further address it. And this brings us to the current research that I'm presenting to you guys today, which is discovering the landscape, what is happening with biologics in CF. So we wanted to understand what are the current practice patterns around the use of type 2 inflammatory biologics in people with CF. Specifically, are there variations in treatment in the identification and treatment of this disease? And we felt like the best way to go about this was to do a national survey of providers. That's exactly what we did. We utilized the CF Foundation email survey group, and we surveyed prescribing providers. And our survey was divided to 3 main sections. 1, demographics, so who are you and where do you work and what is your center size? 2, questions about prescription patterns. So why are you using these meds? How often are you using them? Are you confident in your use and treatment of your patients with these diseases? And then 3, finally, case vignettes. So just some examples of these survey questions. Confidence intervals, so Likert scales. What are you testing for before you prescribe these meds? And just an example of a case vignette. The survey is now closed, but if anybody wants a PDF of the survey just to look at, feel free to message me in the NACFC app or just come up and chat with me. The exciting part, the results. So just to start with our survey response, we received about a response rate of 23% of our centers surveyed. That broken down was about 17% of CF accredited centers and 14% of our affiliated centers. And for those that like tables, this is just a breakdown by demographic, just to show that we had a relatively good balance of our survey respondents. So you can see we had a higher proportion of physicians responding, our directors and our physician non-directors, but a good response from pharmacists and nursing staff. Additionally, we had a good response from adult pediatric and pediatric providers. And then you can see we have a good overall geographic distribution. We didn't have one specific location reporting more than the other. So practice patterns. So something really important is about 85% of respondents reported using asthma biologics. It means 9 in 10 of our CF providers that responded are using these medications. And the most common ones used were dupilumab and omalizumab. And 72%, so over 50% of providers felt like their patients benefited from this drug. And while most of the providers, about 71%, reported 0 to 10 patients at their center on this medication, about 10% reported more than 20 patients at their center on a biologic, which is really astounding. And the most common reason that people reported using biologics were treatment of ABPA, asthma, and nasal polyps. And probably the most important thing to take from that last one is ABPA is probably where we have the most robust data on the use of biologics in CF. So case vignettes. So the last part of our survey were 4 case vignettes. And these were divided into a case of persistent asthma with a patient not on medications, a case of persistent asthma on a patient on maximal inhaled agents, patient on oral steroids or steroid-dependent asthma, and then a patient with ABPA. And as you'll see in the next figures, case 2 and case 4 showed significant variations in response from providers. So just kind of an early spread of how people responded. So in the survey, you were presented the vignette, and then you were given a list of treatment options. And you could select multiple. You didn't have to rank them, but you could select multiple. And this just shows overall how people responded. And you can see for case 1 and case 3 kind of on top of each other, there wasn't a huge variation in response. Everybody seemed to be on board with the next step. But when you got to case 2, a patient with severe asthma on maximum therapy, and case 4, ABPA, you can see the responses were very heterogeneous, or had significant heterogeneity. Another way to display this is a mesh network plot. For those that are not aware, this plot, each circle represents a treatment option, and then the lines between the treatment represent a coupled response. In other words, if someone selected both steroid, for example, and biologic. And the bigger the circle means the more people selected a response, the bigger the line means the more people coupled those responses together, if that makes sense. But the biggest takeaway from this is if you look at case 1 and case 3, it's nice, it's pretty, it's clean. Very clearly, everybody's on the same page about treatment. But when you look at case 2 and 4, if you're familiar with these network plots, this is actually really muddy and we'd even call this chaotic. There's a lot of variation in this response. And so that was really important because we saw in the case vignettes there is significant variation in response to the treatment and identification of type 2 inflammation in our case vignettes. Of course, recognizing the limitation, it's a case vignette, you have limited information, you need to make a kind of decision. And so, of course, if you ever see variations in treatment and identification of disease, you want to know, is there a subgroup where this issue is particularly strong? Is there a group we can identify and help? And the big takeaway is the answer is no. This is actually a global issue, which is super important to recognize. So looking at different subgroups, we try to divide out, different options. So looked at pediatric versus adult providers. Is there a difference in identification and treatment of type 2 inflammation? The answer is no. And then we did a sensitivity analysis, including our med-peds providers, and the answer remained no. There is not a variation in treatment. Additionally, we looked at center size, larger centers, smaller centers. Is there an area that we can pick out where we could be helpful and try to figure out where this variation is coming from? And while we saw a hint of this, and I'll kind of get to that in this slide, the overall answer is no. There is not a difference between large and small centers. We did see a hint that larger adult centers versus larger pediatric centers had a variation in treatment, but when we did additional robust sub-analysis, that didn't pan out to be statistically significant. And while we could have been limited by sample size, the data just really didn't support that this variation existed between those two things. And looking at predictors, there's really only one consistent predictor for the identification of type 2 inflammation and use of biologics, and it's really not surprising. When we looked at people who responded in the survey that they were very confident in their ability to identify type 2 inflammation, and they felt very confident in their prescription of biologics, that was the group that was most consistently both responding they were using biologics and being able to identify type 2 inflammation in our case vignettes. So again, this is not surprising, and it really emphasizes outside of people that routinely use these medications, this is a global gap. In other words, there's not a specific group that we can target. And then we just did some additional sub-analysis within our case vignettes just to see if there's any predictors for people that were more likely to use antibiotics in our type 2 inflammatory case vignettes. And there were, again, no strong predictors. Again, kind of emphasizing this is a global kind of deficit or gap. Now, of course, in any survey study, we have to acknowledge some limitations, and that includes non-response rates, knowledge practice discrepancies, and recall bias. But again, in a situation where we have no landscape, no background, we felt like this overall at least gave us a good idea of what is going on. So, big takeaways from all of this. Despite limited data on the use of biologics in people with CF, our CF providers are in fact using asthma biologics. 9 in 10 respondents, 90%. And there maybe was a hint that larger adult centers were more likely to use these medications, but overall that was not strongly significant, and this appears to be an overall global issue without a specific group to identify. And our case vignettes showed significant variation in treatment identification and actual delivery of treatment in people with type 2 inflammation and cystic fibrosis. And 91% of our respondents stated that further research or guidelines are needed for the treatment of asthma and type 2 inflammation and CF. And now that we understand the general landscape of how often these medications are being used and why, this allows us to take our next steps towards our multi-center study, looking at the use of biologics in people with CF and looking at outcomes including time to exacerbation, pulmonary function tests, and quality of life. So I just would be, it would be silly if I didn't acknowledge all the wonderful people on my team and my mentors, starting with Dr. Dave Young and Ted Lill at the University of Utah, and then Dr. Xi Jinping at the University of Michigan. And then some excellent, wonderful grant support from our people at University of Utah, Judy and Alice, as well as very grateful to the CF Foundation for their support of this study. And then finally, we have a very large collaborative team for our multi-center research study, and they also helped with the making of this survey. So incredibly grateful to them as well. And that is all I have.
Thank you so much for that lovely presentation. As a reminder, we're going to reserve the Q&A for the very end. So I'll go ahead and introduce our next speaker. This is Dr. Brittany Wright, who earned her Doctor of Pharmacy from the University of Iowa College of Pharmacy in 2014. She went on to complete PGY1 and PGY2 residency training in ambulatory care and subsequently developed clinical pharmacy services within the pediatric and adult pulmonary clinics at the University of Iowa. Board certified in ambulatory care pharmacy, Dr. Wright is active in both didactic and experiential education and has served on several local and national committees, including with the CF Foundation. In the summer of 2025, she recently accepted a new adventure and moved across the country to join the University of California, San Diego as an assistant professor of clinical pharmacy. Her clinical and research interests include cystic fibrosis, asthma, non-CF bronchiectasis, rare lung diseases, medication access, and payer systems. She's also passionate about interdisciplinary education and training. Dr. Wright will be presenting on the financial and administrative impacts following changes in the pharmaceutical limited distribution network.
Thanks, Steph. Awesome. So here's my disclosure. And as just mentioned, I'm going to be talking about the financial and administrative impacts on people with cystic fibrosis, pharmacists and pharmacy technicians at CF accredited care centers following changes in pharmaceutical limited distribution networks. I had to scrunch things just to fall into the character limit, so thank you. I'd like to take a minute to acknowledge the collaborators on here. Many of which that are in this room. So Carissa, Molly, Lindsay, Julie, Cameron, Rebecca, Linda, Billy, Casey, Hillary, Nicole. Dave is up on the top, kind of hidden with the other on the third column. But thank you all. This has been great. I will be using several presentation abbreviations. These aren't new to a lot of people in this room, but I thought for completeness we'd add them. So person or people with CF, CF accredited care centers, integrated health systems, specialty pharmacies, cystic fibrosis, transmembrane conductance regulator, modulators, as well as limited distribution networks. All right, so I'm sure everyone in the room understands the substantial impact that pharmacy teams can have on patients with cystic fibrosis over the years. These interventions have spanned from medication access to adherence to antimicrobial stewardship, and more recently with new experiences with CFTR modulators. This excitement culminated last year, actually right before this meeting, when pharmacists and pharmacy technicians were encouraged and named to be required members of the CF care team. I'd also like to familiarize you with a model, including the CF accredited care center, as well as the integrated health system specialty pharmacy. So as members of the CF care team, we know that frequent communication is crucial for our patients' health. I'd like to take a little bit of a pause and do a survey. So can you please raise your hand if you've never been on an endlessly long phone tree? Okay, could you raise your hand if you have never talked to someone who's never heard of CF before? Yeah, good, so no hands raised. This is the same experience I had for 10 years of working in the CF clinic. As evidenced on the previous slide, we know that medication initiation can be completed sooner and more consistently, and actually be sustained when we have pharmacy on board, and serve as a liaison between people with CF, the CF care team members, as well as pharmacy and insurance. We also know that these communication pathways are met with less resistance when utilized with internal processes and medication approval. So that is what I just said there. So the goal of our study was really to quantify the time pharmacists and pharmacy technicians at CF accredited care centers spent triaging and resolving errors, categorizing the type of interventions required, and then estimating the financial burden for people with CF averted through interventions following an announcement in November 2024 regarding a significant change to the limited distribution network of CFTR modulators, and what we found to be impacting medication access for a large number of our patients. So the methods of our study was a retrospective review of pharmacy team members' interventions and interactions during this change from November 1st of 2024 through the end of February 2025. For each encounter, we looked at who completed that intervention. Was it a pharmacist or a pharmacy technician? We looked at the type of intervention that was categorized. We also looked at the time invested to resolve the encounter issue. And lastly, we looked at any resultant changes in billing charges, if applicable. And each site either received IRB approval or exemption. So I mentioned the collaborators earlier, but we had a total of 6 CF accredited care centers and providing care to nearly 1,800 people with CF. Out of these patients, an additional 465 interventions were required, over 216 patients with CF, following this change in required dispensing pharmacy for their modulator. You can see here, most issues did require multiple interactions with a median of 2, but I just want to call out this range that one intervention did require 19 touch points for resolution. In terms of the team members involved, pharmacists provided support for 45% of these interventions, with pharmacy technicians aiding 55% of the time. So what were the interventions that we saw? 39.8% were related to billing and copay coordination. So this could have included helping determine primary and secondary insurance. This could have helped obtain and correctly apply manufacturer assistance. This could have included correct utilization of third-party grant funding. Additionally, we had over 14% of patients, the interventions requiring prescription or therapy clarification. Nearly all of these instances, the clarifying question was actually included on the prescribing information to the pharmacy. And then lastly, 6% were prior authorizations, and I'd like to refer everyone back to that model that we use, and most pharmacists and pharmacy technicians that are involved in that model ensure that all insurance prior authorization work is completed before actually sending that prescription to avoid these kind of issues and improve the transitionary care. So in terms of the time that we found on our study, over our 4-month study period, we were able to track over 200 hours of time utilized by pharmacists and pharmacy technicians per patient. So out of the 216, you can see the median, as well as those longer, the high end of that range of 382 minutes to resolve. In terms of the financial impact, so again, over our 4-month study period, we identified and averted the cost of over $226,000. This calculation included inappropriate billing to insurance, incorrect copay utilization based on insurance structure, incorrect billing to third-party grants, and unfortunately also an instance of incorrect quoting of patient price to the patient. So the big picture. So CF centers included in this study were large, but we know it's not all-encompassing of our entire CF family. When extrapolated to the larger CF community, we estimate that over 3,700 hours could have been accumulated in this 4-month time period. We also found that if this same structure held true, it would be over $4.2 million of averted costs to patients. These figures are representative, again, of only our 4-month study period and not the continued efforts of pharmacy teams on a daily basis. Unfortunately, we also feel that these numbers are likely an underestimation, given the lack of pharmacy support still at 25% of CF centers across the country. So what's being done? We acknowledge that there are programs in place to help bridge these gaps and provide seamless care to people with CF care teams, as well as pharmacies, such as manufacturer liaison programs and CF-specific concierge personnel. However, we still feel that this role is best suited for individuals directly at the care of patient. Improved access to communication to pivotal parties, including care teams, availability of the most up-to-date information included in electronic medical records, and most importantly, patient trust puts pharmacists and pharmacy technicians at the forefront for this liaison role. So what needs to be done? This conclusion paragraph is actually directly from our abstract. It's in bold on our poster. But we urge payers and pharmacy benefit managers, as well as pharmaceutical manufacturers, to recognize and prioritize the critical services that are provided by clinical pharmacy teams at CF-accredited care centers, and the vital role that they play in improving outcomes, providing cost-effective care for patients with CF, especially during times of potential interruption. So with that, thank you. I will be at the poster this afternoon, poster 470. And then I would also like to bring your attention, I serve as a member of the CF Foundation's Financial Wellness Committee, and we talk a lot about just affordability. And so by scanning this QR code, it'll take you to an interest form where you can say if this is interesting to you or other potential topics. And then post-conference, we will follow up with you with additional resources that you may find beneficial. So thank you.
Thank you, Brittany. That was wonderful. Our next speaker is Robin Palmer. So Robin is a pediatric clinical float pharmacist at UNC Children's. She earned her Doctor of Pharmacy degree from the University of North Carolina at Chapel Hill and went on to complete a PGY1 residency in acute care and a PGY2 residency in pediatrics at UNC Medical Center. During her residency, Robin became involved in pediatric CF care through her research project, which she later presented at the Pediatric Pharmacy Association annual meeting. Her training and practice experience span a broad range of pediatric specialties, supporting safe and effective medication use within the inpatient setting. Outside of pharmacy, Robin enjoys following collegiate and national team swimming, having been a member of the UNC swim team during her undergraduate years. Robin will be presenting on the impact of pharmacogenomic profiling on medication use in pediatric patients with CF.
Thank you so much for that kind introduction. As she mentioned, my name's Robin, and I'm a pediatric inpatient pharmacist at UNC Children's, which is a part of UNC Medical Center in Chapel Hill, North Carolina. And today I'm going to be presenting on what was my PGY2 research project, the impact of pharmacogenomic profiling on medication use in pediatric people with cystic fibrosis. Here are my disclaimers. And before going any further, I do want to acknowledge that this study was funded by Friends Fighting Cystic Fibrosis and the Cystic Fibrosis Foundation. For some background, the Clinical Pharmacogenomics Implementation Consortium, or CPIC, creates evidence-based guidance for medication management based on pharmacogenomic data. In current state, there are 164 medications with published CPIC guidance, which means that there are evidence-based recommendations for how to adjust drug therapy based on a patient's genotype. There are also 166 medications with provisional CPIC status, which means that there is enough data that a guideline is either planned or currently in progress. And the reason that this is so important in our CF community is that it is estimated that 97% of adults will have at least one reported pharmacogenomic variant. And when we look at medication use, we have seen that over 75% of people with CF will take at least one medication with an actionable CPIC guidance, with almost 20% taking 3 or more actionable medications. When we're thinking about our individuals with cystic fibrosis, we know that they are often taking multiple medications from different medication classes. With our improvements in our survival rates after the introduction of our CFTR modulators, this population is also increasingly likely to be exposed to additional medication classes that will help manage age-related comorbidities, such as our cardiovascular drugs, which we all know are heavily impacted by pharmacogenomics. However, even with all this, there really is insufficient data for the application of how we're going to utilize pharmacogenomic data in our current routine CF medication management. So to further evaluate the use of pharmacogenomics in our cystic fibrosis care, the UNC Pediatric Pulmonology Clinic began collecting pharmacogenomic data in December of 2022. This was first utilized using the InVitae assay. However, due to a change in the manufacturer, we switched over to the AccessDx laboratory assay. On the bottom right-hand corner on the slide, you can see the 38 genes that were reported in our AccessDx pharmacogenomic panel. And on the right side is an example of what the personalized insight that each patient would receive that would incorporate medication recommendations based on the patient's personalized results. Now, it's important to note that this does not necessarily take into account the patient's individual medication regimen, but instead will provide an overall view of different medication classes that may be impacted by the patient's results. Now, we were very lucky that our patients were supported by grant funding, so all pediatric people with CF treated at UNC would receive free pharmacogenomic testing. However, I do want to acknowledge that based on insurance coverage and assistance programs, costs may vary. There are reports of commercial insurance and Medicaid covering some type of pharmacogenomic testing. However, when we do look at the average out-of-pocket costs for a very basic pharmacogenomic panel, it can range anywhere from $150 to $500 out of pocket. However, when we look at our more extensive panels that will do a full pharmacogenomic test, we can see that this can exceed the cost of thousands of dollars. So something to keep in mind. So now as we move into our study design, our research questions were to assess the pharmacogenomic profile of the pediatric cystic fibrosis population at UNC. We wanted to understand how many patients were on medications that were CPIC medications. And then lastly, we wanted to evaluate the use for any additional data that we might be able to use with our pharmacogenomic results. And so here, looking at our methods, this was a single center retrospective chart review that looked at the pharmacogenomic genotypes and phenotypes that were pre-populated from our 2 InVitae and AccessDx profile assays. For inclusion criteria, we included all people with cystic fibrosis that were younger than 20 years of age, that were primarily seen and treated at the UNC Pediatric Pulmonology Clinic between December 2022 and May of 2024. To be included, they must have the full results of their pharmacogenomic panel, be due for clinical labs, and be actively taking elexacaftor, tezacaftor, ivacaftor, or ETI. We did exclude our patients that were not enrolled in the initial ETI drug level and the pharmacogenomics study. And then lastly, for our statistical analysis, we used descriptive statistics for both our primary and our secondary outcomes. And so our primary outcome was overall to describe what the pharmacogenomic profile of our pediatric CF population looked like. Here we can see the CYP and the non-CYP enzymes that were included in the study. The reason that these ones were selected is that they were more likely to be impacted by medications that our patients were currently taking. I do want to note here that the NAT2 and the SLC6A4 genes were not reported in both and instead only reported in one of the 2 assays. Our secondary outcomes included determining the proportion of people with cystic fibrosis that were on medications with CPIC recommendations. And to do so, all active medications that were being recorded at the time that pharmacogenomic testing was collected was cross-referenced with the most up-to-date CPIC guidelines. And we included all maintenance, as needed, and acute medications at the time of pharmacogenomic testing. And then lastly, we aim to determine the number of actionable medication changes based on CPIC guidance. And so to do so, we classified the number of actionable medication changes on a range of 0 to 2 or more medication based on CPIC guidance. And for this study, actionable was defined as a medication that warranted a dose adjustment or modification based on the patient's individual pharmacogenomic results and a CPIC guideline. So now to move into our results. Here we can see a baseline characteristics of our study population. The average age of our participants was roughly 10 years of age, with 97% of the population having at least one copy of the F508del CFTR mutation, with roughly half of the population being homozygous. There was an even split of the type of pharmacogenomic assay that was utilized, so 50-50 between our Invitae and our AccessDx. And when we looked at the average number of medications that were recorded at the time of pharmacogenomic testing, we can see that the number was 12. Now, as we move into our primary outcome, here we can see a visual description of what the pharmacogenomic profile for our pediatric CF population looked like. And phenotypes were going to be categorized based on metabolizer status, based on CPIC classification. We can see that there was a pretty wide range of those with phenotypes that were reported as normal metabolizer status, as well as compared to variant metabolizer status. One thing I do want to draw your attention to is up at the top for our CYP3A5 metabolizer enzyme. What we would consider poor metabolizer is actually going to be considered normal. So we can see that a majority of our population did have normal metabolizer status. And again, here is that same data for when we move into our pharmacogenomic results for our non-CYP enzymes. We can see here that there was a pretty wide distribution of those that had normal phenotypes compared to our variants. However, I do want to acknowledge that we did not include the two genotypes that were not included in both assays on this diagram. Now, as we move into our secondary outcomes and look at the proportion of patients with CF on medications with CPIC recommendations, we can see that there was a total of 787 active medications at the time that pharmacogenomic testing was collected, with 42% of these medications found to have CPIC status. When we look at those with CPIC status, it's not surprising to see that a large proportion of these were our CFTR modulators as well as vitamins, but we can see some additional medication classes as well. Now, when we were cross-referencing our medication to CPIC guidelines, we saw a total of 35 medications, or 4% of medications, that were found to have actionable CPIC recommendations. As we can see here on the left-hand side of this slide, a majority of these medications included our gastrointestinal agents, such as our PPIs or proton pump inhibitors, as well as our psychotherapeutic drugs. On the right-hand side of this slide, we can see that all the medications that were found to have actionable CPIC recommendations and their associated genes. Of note, the genes for amikacin and tobramycin were not collected on our assays in this study. However, I did include them on this slide for completeness sake. Now, lastly, as we're bringing this down to the patient level, we saw that 16 patients were prescribed CPIC medications with unfavorable pharmacogenomic pairings, meaning that there was published evidence to guide clinical management for 24 prescriptions based on the individual's pharmacogenomic profiles. A majority of these medications of these individuals were only taking one medication that required actionable change, while 5 were actually taking medications that did not have dose modifications or adjustments, but were more deemed as informative. When we're looking at all the medications that did require actionable change, we can see that they involved our CYP2C19 or CYP2D6 enzyme, which is not surprising, with almost 90% of the medications that were impacted being our proton pump inhibitors. Now, as we gather this information, there's a lot of question of what we want to do with this data. So as far as our future direction, there have been some discussions on how to best incorporate our pharmacogenomic data into our current health system's electronic health record. There has been some discussion with our team about piloting integration of our commonly impacted CYP enzymes, such as our 2C19 and 2D6, as we know that this was impacted in all of our medications that required actionable change. Again, there's some other various places that we can place this in, either having it listed as an allergy or a BPA. However, there's still a lot of discussion on how to best integrate this, as we know that there is often a lot of alert fatigue with our current EHR at current state. And so as we move into our conclusions, we saw that on average, our people with CF exhibit variants in approximately 50% of the CYP enzymes that were tested in this study. Almost half of our people with CF were prescribed a medication impacted by pharmacogenomics, which really highlights the importance of integrating pharmacogenomic data in our routine CF care, specifically as we're seeing improved survival rates with our patients and more likely coming in contact with medications such as cardiovascular drugs that are more heavily impacted by our pharmacogenomics. And with that, I'd be happy to take any questions at the end of the session, and I will also be presenting this as a poster. I believe I am 474. Thank you.
All right. Next, I would like to introduce Dr. Franz Fosek, and he is a methodologist and pharmacometrician at the Clinical Research Unit of Necker-Cochin Hospitals, all the way from Paris. His work focuses on clinical biostatistics and biomathematical modeling, primarily in pediatric and perinatal pharmacology. He is also the co-leader of the modeling group within the UMR 1343 group, which is a research team dedicated to the pharmacological and therapeutic evaluation in pediatric and maternal populations. He wanted to share a fun fact that he first came to Seattle 13 years ago for a conference, but didn't get the chance to see the Jimi Hendrix statue, and he's hoping to do that this time. Dr. Fosek's going to be presenting on the physiologically based pharmacokinetics of ETI in children with CF.
Thank you, Stephanie, for this nice presentation. Thank you, everyone, to be here. My talk will focus on physiologically based pharmacokinetics of elexacaftor, tezacaftor, ivacaftor, ETI in children with cystic fibrosis, and particularly on the fact to extrapolate the dosing regimen in infants. I have no conflict of interest to disclose. As many of you are aware, currently ETI is approved for children over 2 years of age, while ivacaftor monotherapy is approved in children 1 month and older. We assume that an early ETI initiation in infants could improve the clinical outcomes, and for that we have to determine the dose dosing. For most of the CFTR modulator dosing recommendation in children, the drug dosing are based on age and weight, reflecting its complexity. But it's even more challenging for infants because of the rapid growth and organ maturation during early life. To illustrate this, this slide will show how developmental changes will affect pharmacokinetics. Regarding Peros absorption, all these factors could modify the bioavailability of the drug. Regarding the distribution, plasma drug protein levels are lower in the first year of life than in adults, and as a consequence, the free fraction of the drug will be higher, the pharmacologically active form. Regarding the metabolism, we know that CFTR modulators are primarily and extensively metabolized. This figure represents the percentage of enzyme adult activity as function of prenatal and postnatal age, and you could see 3 different patterns, a constant pattern from prenatal to postnatal age, a prenatal pattern with very high enzyme activity before birth, and a postnatal pattern with an increasing activity as function of postnatal age. Regarding the X question, the acquisition of renal function will also slowly mature, beginning in utero, to reach for the glomerular filtration rate approximately at 2 years of age. So the objectives of this study were to use in silico modeling to predict the pharmacokinetics of ETI in infants, and to further evaluate if age and weight ETI dosing regimen extrapolated from the current dosing recommendations, keeping the current drug ratio between drugs as in adults, will achieve ETI drug exposure similar to those observed in adults. For this, we used the physiologically based pharmacokinetic approach, also known as PBPK. This approach uses mathematical models that integrate physiological, biochemical, and drug-specific parameters to describe the overall PK profile. The classical workflow will be first to develop a PBPK model in adults, and once we obtain good predictions, we could then scale and extrapolate the different PK and anatomy parameters to children. To develop our PBPK model, we use the SimSip software. This software takes into account the overall developmental changes that I just mentioned. So it's a really good software for that. And it allows also to simulate different dosing scenarios. Here I will detail the workflow we used. So in the first step, we aim to predict the ETI pharmacokinetics in adults. And for that, there is already a PBPK published study by Tsai et al. So we choose to replicate the published models and to validate them against in vivo PK data in adults. The second step, we aim to predict this time the pharmacokinetics in children aged 2 years and more. And once again, we validate the prediction with in vivo PK data. For the third step, we focus on the EVAC factor PBPK model, and we try to extrapolate the PK in infants from 1 month of age. This time we use a literature data source to validate our models, one study from McNally et al., and we also simulate the current EVAC after dosing recommendation. Finally, we also extrapolate the TESAC after and ELEXAC after kinetics in infants. And we first evaluate our predictions with internal data coming from children receiving ETI as under compassionate use authorization. And finally, we simulate the extrapolated dosing regimen. Regarding the dosing simulation, for each dosing regimen, we simulate approximately 200 virtual patients at steady state. So for the step 1, we simulate the current adult recommendation. For the step 2, the current children dosing recommendation. For the step 3, the EVAC after monotherapy current recommendation. And for the step 4, so we simulate the extrapolated ETI dosing from the EVAC after monotherapy that are shown here, keeping so the drug ratio existing in all formulation. Regarding the validation data source, we use the pediatric data comes from the module CF French cohort study led by Professor Sermet-Godlus. Regarding the adult data, they come from the French National Observational cohort study led by Professor Burgel. We use different validation criteria to validate our models. First, the goodness of fit plots, which compare predicted versus observed data, PK profiles. But also, we perform quantitative comparison on the steady-state pharmacokinetic parameters, such as area under the curve, maximal and minimal concentration, using a mean-fold error index. I'm coming to the results part of this presentation. So for the first step, as I told you, we use previously published ETI PBK model by Tsai et al. That provides input parameters. On the right, you could see a table detailing the input parameters with specific drug properties and other parameters standing for the PK processes. Here are the goodness of fit plots we obtained for this first step. Each dot represents an in vivo drug concentration as function of time after the last administration. And the median red line represents the median of the predictions we obtained. And the dashed line, the 90% prediction interval. As you could see, the prediction fits the data. For the step 2, here also you have the goodness of fit plot we obtained after scaling the adult PBPK model to children aged 2 years and more. So for each drug you have the prediction obtained, and it's also presented as function of the drug dosing recommendation. Once again, we obtain a reliable prediction. For the step 3, focusing on the extrapolation of the EVAC after PBPK model, we first evaluated the prediction with McNally et al. Published data. So this time the figure represents not the PK profile but the drug exposure for the 2 dosing regimens that evaluated McNally et al. The points and triangle symbols represent the observed reported data, and the box plot the obtained prediction with the EVAC after PBPK model. So we see that we obtain also in this very young children reliable prediction. And we also add the red line stand for the median adult EVAC after target, drug exposure target, and the blue area, it's a 90% confidence interval. Then we also simulate the current dosing recommendation of EVAC after. So the box plots are the prediction drug exposure as function of the different dosing group. Overall, we could see that most of the infants reach the adult target, but not in the younger children. Like the McNally study, I don't precise it. So we estimate that we obtain good results. So we try to extrapolate TESAC after and ELEXAC after PBPK model to infants age 1 month and more. And we first validated our prediction with data of a few children who received ETI under compassionate use authorizations. So here are shown the observed concentration for one child age 8 months. And we could see that the predictions fit overall the data. This is the same, it's for another children who receive the same ETI dose from 7 months of age to 13 months of age. And we performed blood sampling at different occasions. Finally, we try to simulate the extrapolated ETI dosing recommendation. The ETI extrapolation of doses based on the EVAC after monotherapy. And here are the drug exposure we obtained. So the box plot stands for the predicted drug exposure. for each drug, and it's also present as function of the drug dosing of the different drug dosing groups. Overall, we could see that the drug exposure matched the adult target drug exposure reference, except in the youngest children who have lower drug exposure prediction, and maybe in the patients with weighing more than 40 kilograms, the last group, who could have higher exposure than reported in adults. So, PBPK modeling and dose extrapolation could offer a starting framework to predict drug dosing in infants. However, the absence of a well-defined pharmacokinetic pharmacodynamic relationship in the cystic fibrosis infant population, as well in adults, underlines the preliminary nature of the current findings, especially in the 1 to 6 month subgroup, where extremely limited data are available, particularly for elexacaftor and tizacaftor. Voilà. From a clinical perspective, a gradual stepwise initiation of ETI is advisable in adjunction with a close clinical monitoring and therapeutic drug monitoring to ensure safety and tolerability. To conclude, it's the first study to characterize the clinical PK of ETI in infants using a PBPK modeling approach. The simulations of ETI doses based on ivacaftor monotherapy matched overall the adult reported level, except in the youngest children who have lower exposure, and in patients weighing more than 14 kilogram, who may experience higher exposure. The absence of a clear PK-PD relationships highlights the preliminary nature of these results and the need for further clinical investigation. I would like to address an acknowledgement to Oa Truong, which is a PhD student who performed most of this analysis, and he will be the poster presenter this afternoon. Thank you for your attention.
Thank you, Franz. A reminder that, if you have any questions, feel free to put them on the app as well. And our next presenters are Sylvia and Sally. So Sylvia M. Caceres is currently affiliated with both the University of North Carolina at Chapel Hill, where she works as a research coordinator, and National Jewish Health, where she serves as a senior lab researcher. She holds a bachelor's and master's degree in biology from Universidad de los Andes in Bogota, Colombia. Since joining the adult CF clinic at National Jewish Health in 2010, Sylvia has developed a strong interest in non-tuberculous mycobacteria and microbiology in CF patients. She currently balances 2 part-time roles, a remote position at UNC coordinating the creation of an NTM biobank and supporting a multi-site NTM study called PHALT, and an in-person role at NJH, where she manages multiple responsibilities across clinical and research settings. Outside of work, Sylvia is an avid skier and leads a women's ski club in Colorado. During the summer, she enjoys gardening and camping. And our second, co-speaker is Dr. Sally Abulanin. She is a biomedical information and clinical researcher with a strong background in medicine and translational research. She earned her MBBCH in medicine in 2002, an MS in rheumatology and rehabilitation in 2011, a certificate and MS in clinical and translational research in 2015 and 2017, and a PhD in biomedical informatics in 2024. Dr. Abulanin is currently a postdoctoral fellow at the University of Arkansas for Medical Sciences, where she specializes in data analysis and machine learning for biomedical research. Her current work focuses on pharmacokinetics, pharmacogenomics, predictive modeling, and precision medicine in cystic fibrosis. Outside of research, she enjoys spending time with her 2 daughters, making arts and crafts for friends, and exploring healthy cooking and fitness. Together, they will be presenting on modeling a single variable time measurement of elexacaftor, tezacaftor, ivacaftor in adults with CF.
Thank you, Lori. So we have no disclaimers, but I just want to thank the organizers and the chairs who put together this amazing workshop. So thank you very much. So our talk this morning is modeling a single variable time measurement of elexacaftor, tezacaftor, ivacaftor in adults. Like I said, we have no disclaimers, but we do have a disclosure. We were supported by National Jewish Advanced Diagnostics Laboratories on developing this study. So as background, most of you know a single dose of ETI was approved for people with CF in the US since 2019. And despite the efficacy of ETI, most people with CF, ETI dosing is often modified by people with CF or their clinicians. Since 2023, ETI plasma concentrations have been quantified at the National Jewish Health Adult CF program in Denver, and it's normally done during routine clinical care. The test validation and preliminary results were shown here at NACFC last year. So the test is available to all US CF centers through National Jewish ADX laboratory. So our aims for today's talk are to model the ETI concentrations to predict average plasma concentrations, to test the variability and overlap of ETI levels in plasma among people with CF on full or modified doses and at clinically convenient time points, to explore the potential applications of the test. So in terms of samples and processing, plasma samples were collected from people with CF 18 years or older at our clinic. And people with CF using full or modified dose, this modified dose could have been half dose, flipping the pills, a quarter dose, all of them are kind of included or grouped in this modified dose. Samples were collected, like I said, at a single variable time point during a routine clinic visit, and the samples were processed by ADX at National Jewish, who validated and developed an ETI HPLC assay. So I'm going to let my co-host talk about the model since she's the one who did all this work.
Thank you, Sylvia. Thank you. Hi. I am Sally. I will present the methods we used. We have study data. Our study data contain of 26 participants, and we have about 9 samples. We collect 9 samples from each participant, and during these samples, we have blood tests to collect it from them, and we have 234 samples from each participant in each drug. Okay, so according to this data, we have a strong data. We can collect, it is from 0 to 12 hours. Okay, we have, but we don't have at hour 3, 7, 9, and 11. And that's what we did. We used supervised machine learning. If you know the supervised machine learning, the difference between supervised machine learning and unsupervised machine learning, there's a supervised machine learning that you know the outcome. And because we have the data, which is about 9 samples from each participant, we can know the outcome, which is the C average. So this is supervised machine learning. So we go back and predict the each model to predict first the missing times, and then we predict the models for each one. What make our model strong, actually, that we use the accuracy, 3 matrices for the accuracy. Okay, we use the average bias, the R squared, and the coverage rate. Okay, we need the R squared to be high, average bias to be low, coverage rate to be high. In that case, the model is good. Okay. Our goal to identify the optimal time points. We can use 1 sample, 2 samples, yeah, for the accuracy of the C average. We predict that we can use only one sample. That's good. And we also predict that the best time is 6. But here, I'd like you to see that the linking point that we predicted is as unsupervised machine learning. We predict the missing points, the 0, the 3, 7, 9, and 11, because they are not in our data. We have the other points in our data, so we predict them, and according to that, we made our models. Here is the radar chart. In radar chart, we can compare the models together. Okay, we compare in each drug, we compare the model. So, and according to that, we have the 6 hour is the best one. Okay, of course, we have the model for each, for all time points, but the best one or the most accurate one or the one we recommended is the 6 hours. And you can see all these things on my poster in 487. Okay. Okay, so now the single time point study is a 6 hour. This is the ideal. Okay, and then according to our data, we estimate we get the beta coefficients, and then we go back to the National Jewish Health data and predict their data. So it is collaborate between our data and their data. We use our knowledge with them to help them and get the modeling for their data. We impute the missing time point and get our data sets. So now we have the model for all of them, their random samples, and we predicted them. And we compare our previous reported with the C minimum, C maximum, and the EC50. And now back to Sylvia. Thank you.
All right, so now to results. So the National Jewish data consisted of a total of 148 samples from 121 unique adult participants, which most of them were on a full dose. In terms of their demographics, gender, age, and BMI significantly differ between the two groups. The genotype was not significantly different, but we do see some trends that are a little bit different between the two dosing groups. In terms of their clinical characteristics, the baseline FEV1% predicted was not significantly different, and most of the patients were taking enzymes as well. The time since last dose, and this is when the sample was collected, that's when the patient went to clinic, that significantly differed between the two dosing groups. So the full dose was closer to the 6 hour time point that Sally was talking about, 6 hours and 42 minutes, and the modified dose was closer to 8 hours and 3 minutes. We're also showing here the difference in dosing. Like I said, the modified dose does group different strategies for taking ATIs. So now to the interesting data. So these are the raw data, and I'm going to show you the raw data first and then the modified data so that we could kind of see the trends that we see if you just get the raw data, right? So here you see elexacaftor, tezacaftor, avacaftor concentrations for the full dose, which is the black circles, and the modified dose, which is the squares. The beige area represents the maximum concentration, the gray area represents the minimum concentration, and the blue line is that EC50. So what we saw was that the median concentrations between doses were statistically significant between groups. There was variability and considerable overlap for dose strategies. And when you look at the full dose group, there is a higher percentage of patients above the Cmax when compared to the modified dose. For the subjects on a modified dose, they did have significantly lower ETI concentrations and a higher percentage below that EC50. So here is the model data. And the model kind of restricted us to samples that were collected between 0 and 10 hours from their last ETI dose. The model also, of course, couldn't model data that was below the limit of detection. So by restricting it, we ended up with just 85 samples from the full dose and 26 samples from the modified dose. And here's the model data. So we see, again, median concentrations between doses varying or being statistically significant between the modified and the full dose for all three drugs. Variability and considerable overlap for both dose strategies remained, and then the higher percentage above the Cmax for modified doses remained. There was, of course, because we removed those below limit of detection values, we didn't see that many people below the EC50 with the the model data, but significantly lower ETI concentrations for the modified dose remained. So this is a little bit of preliminary analysis. We want to compare, we want to see what happens if you stratify the data. So if you take the raw data and stratify by genotype, in the full dose, we observe elexacaftor, tezacaftor, and NAVA concentrations varying. If you take it by genotype in the modified dose, elexacaftor and ivacaftor concentrations varied, and no significant differences in ETI levels were observed with either dose when stratified by gender, FEV1, or BMI. How did it look with the model data? So IVA concentrations vary by genotype in the full dose. Elexacaftor concentrations vary by genotype in the modified dose, and no significant differences in ETI levels were observed with either dose strategy when stratified by FEV1 or BMI. We did see gender differences between females when you compare the full versus the modified dose for ivacaftor and tezacaftor, and we saw differences between the full and the modified dose when compared in males for ivacaftor. So what do? What does this mean? How do you interpret these results if you get this test done in your clinic? So our recommendations basically are, if your C values are very low, consider poor absorption or not adherence from your patients. If values are extremely high, check the medication list, suspect increased risk of toxicity, and utilize label-based dose adjustment. I do want to point out that our patients that were on a modified dose, or the data that I'm showing you from the modified dose patients, this was prior of us doing this analysis. So they were just modifying their dose because they felt better or the clinician felt like it was a good recommendation. Put levels into context. Focus on the FEV1, the BMI, the number of exacerbations, and the individual symptom. The test is just going to give you a number. Use levels to explain unexpected responses, and document and share the TDM. Data collection, tracking, and sharing local results helps us build consensus. So in conclusion, real-world ETI concentrations demonstrated wide variability. And this has been described in the literature and many other presentations in this conference. Individuals receiving a full dose did exhibit a higher C average when compared to the modified dose, but these dosings still overlap between individuals on a full dose or a modified dose, and most of them achieve concentrations above EC50. These findings also suggest that many people with CF may achieve therapeutic ETI concentrations even at reduced doses. And predicting a C average from a single point is feasible, and it might be a really good strategy to identify people with CF at risk of having concentrations outside their pharmacokinetic target range. These results highlight the trade-off between achieving therapeutic concentrations and avoiding excessive exposure. Additionally, it supports the idea of TDM integration into routine CF care, and limitations to the study include the racially, ethnically homogeneous population at a single site, the smaller size of the modified dose group, and the increased variability in sample timing in this specific group, which might have interfered or has an effect in the robustness of the comparison. And do remember, results inform but do not dictate clinical decisions, especially in complex cases. Prioritize patient-centered outcomes and follow label dosing. But personalized ETI dosing strategies are possible. And I would like to thank our Colorado Adult CF clinic and research teams, the ADX team at National Jewish, and of course, our amazing collaborators at Arkansas Children's Hospital. Thank you.
Thank you to all of our speakers for their insightful presentations. And at this time, I'm going to go ahead and invite all the speakers back up to the podium, and we'll open up for questions. So again, please feel free to add them to the app. Right now, I see about 2 or 3. And you're also welcome to use either of the microphones if you would like to just ask the question yourself. So while we're getting everybody back up here, my question for Sylvia, can you remind us, for those that are unfamiliar or who haven't done ETI concentrations, like what's the process for referring to National Jewish, those levels?
It's a really good question. And I think Ryan, I don't think he's here, but he's here. He is the representative for the ADX National Jewish team. They have a booth down in the exhibition hall. He will be able to give you all the information, but just reach out to the ADX laboratory at National Jewish, and they're here today and tomorrow too. So they'll be able to help you out with that.
Okay, and while you're here, Sylvia, another question for you from the app is, for modeling ETI concentrations with a single sample, could you share how your model performed in terms of bias and R-squared?
Sally, do you want to?
So for modeling ETI concentrations with a single sample, could you share how your model performed in terms of bias and R-squared?
Hi. Okay, our model that we made 3 matrices, the average bias, the precision, and the R-squared. The R-squared we want it to be high. If it is high, it's better. Okay. The average bias we want it to be low, and that's what we did. We choose the lowest bias, highest R-squared, and high average and high. That's okay, and high precision. That's it for.
Thank you to all the speakers. For the last 2 speakers with modeling the ETI concentrations, presumably patients who were on a modified dose of ETI were on that for a reason. Did you see anything in your data that coordinated or discriminated between the concentration that caused whatever side effects were being avoided and the concentration that you actually saw therapeutic effect? And then as a kind of follow-up question to that, would it be reasonable to put patients who experience side effects on a reduced dose of ETI and then check their concentrations in clinic to see if they were above therapeutic levels? Thanks.
Those are really good questions. And the first one, yeah, I have sometimes the patients just decided to modify the dose. And then because they started feeling better, and there were multiple reasons, either mental health or skin issues, but they did feel that when they spoke to the physician felt like it would be good to check if it was at the target, the pharmacokinetic target. So we did that. For your second question, yes, I 100% agree. That is a good strategy. If you're going to modify a dose, we had patients that were pregnant, were concerned and wanted to see where they were at. Patients that were starting new medications and they wanted to see where they are. So we are having those patients, and I think that is a really good strategy to include into your clinic.
My question is for Dr. Palmer.
Yes. Regarding the data I presented, it's only a full dose regimen. Yeah. So we did not study differences with modified or mid-dose regimen and full dose, but I think I agree that even with a mid-dose regimen, EC50 levels are reached, I think, for all drugs.
All right, let's try again. Okay, so we did a prospective study of pharmacogenomics in our population, and included in that was taking this monster report you get from the company that also includes non-actionable genotypes and making it into something that families could understand. And then we surveyed the families about what they thought and if they thought it was valuable and understandable. But the most complicated part of doing that study was getting those reports to the patient level. So I'm curious what you do in your practice to educate the families on what all of that means.
Yeah, no, I can imagine the raw data that I had was pretty overwhelming. However, I think we were very lucky, and the 2 assays that we used did break it down into patient information. And so although that at baseline can be overwhelming since it's going to go over all of the medication classes that could be impacted, again, a lot of these being medications the patient may never see in their lifetime, I think that that's really when we have pharmacy counseling come in, kind of break down, these are the important things that you need to look out for, and really maybe bringing it down on a patient level, looking at the medications that they're currently on and that may be impacted, and maybe bringing out the ones that are most important moving forward. Kind of a big one that comes to mind would be our cardiovascular drugs that can have pretty negative consequences if we're not thinking about pharmacogenomics. But again, I think that is a very hard concept to understand in a pediatric patient that may not be seeing that for a really long time. So I think that what is utilized in practice is just patient counseling, going over what the results mean, but really focusing in more on medications that they're actively on and really saving some of those future conversations for when that medication is being prescribed to kind of make it more digestible to the patient.
Robin, I had a follow-up question for you. At your center, who primarily interprets the pharmacogenetic data at your center? Is it like the Cystic Fibrosis PharmD, or do you guys have a clinical pharmacology department? And any advice in either one of those realms?
Yeah, I will, be correct if I'm wrong, but I do believe that would be Cameron and Carissa, who are outpatient CF pharmacists that are basically doing a majority of it. We do on the inpatient side have a pharmacogenomics group. However, it's primarily based in oncology in the adult setting. So this is not, to my understanding, something that they're really involved in at this time. I think moving forward, they're involved in some of the conversations on how we're going to best integrate the information that we have. But on the current practice and current state, it would be our CF pharmacists that are doing a majority of the interpretation.
Thank you. Go ahead, Paul.
I just have a question about the therapeutic drug monitoring approach. So your recommendation was a single time point at 6 hours, and levels can be altered for different reasons in a patient. It could be a reduced bioavailability, it could be altered clearance. I'm just wondering whether a single time point at 6 hours is going to be able to discern between those two, because how you adjust the therapy is going to be different in those 2 situations.
Actually, we have a model for all hours, not only 6 hours. We made a model from 0 to 12. But I mean that the ideal or the more accurate one is a 6 hour. Okay, this is according to our model. We made a model for, and actually we did for the supervised machine learning. We made 3 kind of models, and we choose this one. This is the best one, okay, from the supervised machine learning. We use the linear, the cross-validation, and random forest. And then we choose this one. This is the best one, and this is the high accuracy one. Good model can be done with other data, because some models, when you use it, it will be overfitting, so it will not be, you can't use it in other data. But this one, we can use it in other data. That's what we use it in National Jewish Health. So yeah, you can use any model you want, or I mean, you can use any hour you want. If you have patient at 8 hours, that's fine. If you have a patient with 0 and 2 hours, that's fine. You can use the 2 time points. You can use any model of them. But I mean that the ideal one, or the one I recommend to use it for the accuracy, for the high accuracy, okay? But other than that, that's fine. You can use anything. And actually, one of the 6 hours, it is good for design the personalize the medication for patient. So in this one, you can follow up because you know this is a good one. You can follow up at the 6 hour every time. You know that with the C average, what's good, or if it is high or slow, if it is in a good shape. So you are good with this medication or not. So this is also good for the follow up more. Thank you.
And just to follow up with regards to the levels as well, a question from the app is just double checking from like a practical and logistical standpoint that the recommendation is to draw the level 6 hours after the orange tabs, right? And then like will reference ranges be provided for this 6 hour time frame that would actually, like what are the targets? The targets is my interpretation of the question. Like if something is drawn at 6 hours, how is it interpreted?
Yeah. We can predict the C average from any time. That's what I'm saying. But the 6 hour, this is a high accuracy. The model is so good in this one because the model is maybe not so good at 2 hour. Okay, or 3 hour, but it's so good at 4 hours. So you know that when you get the prediction, you more than 80% or 90% accuracy. Okay, but in other time you will get that your answer, but it may be not so accuracy. This is the thing.
Are you? I think it was.
And of course, we need more data. We need more analysis. We need these things to predict maybe more model. We also aiming to add another variable to this model. Maybe it will also make help to predict the best time.
And then just as a follow-up to that question, that was kind of part of the reason I wanted to show the raw data and the model data so that you could see that even if you don't have the model available to you in your clinic, the data is still going to guide you and give you an idea if your patient is above that maximum concentration or that below limit. You could also reach out to ADX at National Jewish, and they will be able to give you a little more information if you need it to interpret. And that's why if you're sharing all that information with us, it's very helpful because it creates this consensus for us of how we could interpret the data.
Awesome. Oh, go ahead.
Hi, thanks to all of you. Those are amazing discussions. Thank you very much. One thing I was going to ask about the levels is, from a recommendation standpoint, if you wanted to measure a level in a patient, would you recommend that it be at least after how much time on therapy, particularly if you're wondering about adherence? Second question, would you recommend that we in the clinic setting coach the patient and family about the circumstance prior, the circumstance prior to the draw, meaning like make sure they're taking it for X amount of time with fat, if their pancreatic's insufficient, with their enzymes, like how do we set this level up for success to mean the most? And it may be dependent on pancreatic sufficiency, may not be, but do we, so anyway, those are my questions.
Good questions, and I had those too when we started. We consider for the study, when we did the validation of the test, for the patients to be at least 15 days on ETI, on any dose that they had, but at least 15 days, that would give you a steady state of drug. Yes, we also ask, when did you take your dose? What was your last dose? Did you take enzymes? Did you eat when you took your dose? And so that would also help us with the results, to interpret the results. Because if they didn't eat anything fatty, then, well, maybe this test is not going to give us the result that we're hoping. So that's why, that's kind of one of my reminders. It's just a number. So just think about everything else that is going on with the patient. But that's an excellent question.
Thank you for that follow-up information. The only reason I'm wondering is A, to set the patients up and families up for success, but B, I'm guessing this is relatively expensive, may be covered by insurance, may not be covered by insurance. That brings forward, like, do we serially measure these levels? And if so, how often? And then how expensive? So I wanted to, in my head, set this up for success from the get-go.
Right. Yeah. It depends on the institution, the cost. At National Jewish is not that expensive for our patients at our institution to do the test. There is different pricing for the institutions when they go through ADX, and it is up to the institutions to negotiate that. In terms to the insurance, that again, it kind of depends on the patient's insurance. I don't think is outrageously expensive. We do have some patients that are starting new medications that are maybe they're concerned that they're going to interfere. And so we've been kind of doing like a longitudinal testing. And again, like the pregnant patients, we've also been testing, and that has been very helpful.
Okay, we have a couple of questions in the app for Blair. The first one is, are biologics currently prescribed at your center in the CF clinic, or are patients referred to allergy, for example?
That's a great question. So we do prescribe them in the CF clinic, and then some patients do see an allergist, especially if they have pretty significant sinus disease. And so our allergy department's pretty comfortable prescribing them as well.
And then the second question for you is, did you ask on the survey how often patients are being screened or evaluated specifically for severe asthma or polyps at CF clinic visits?
No, that's an excellent question. We didn't ask that. We did ask indications for biologic use, so we at least have an idea of why people are prescribing it and what testing they're using, but we don't have any sort of ideas around that. It's a good question.
And I personally had a question for you. Do you believe the current diagnostic tools like IgE, eosinophils, phenos are sufficient for identifying type 2 inflammation in people with CF?
That is a great question, and that's actually an area of a lot of research because current clinical data states that phenos don't tend to be elevated in people with cystic fibrosis. Eosinophil counts, there's also controversy around this. There's some research that also shows that number doesn't tend to be elevated, but IgE levels do appear to be. And the good thing is at least that is one of the indicators for getting on biologics. It, just from personal experience and talking with colleagues, I think probably our strongest indicator for being able to get people easily on it is sinus disease, sinus polyps.
Great, thank you. I think we have a question for Brittany around what strategies have proven most effective in streamlining communication between like CF teams, insurers, and external pharmacies.
I mean, I do think with CF teams, there was part of the discussion of when you have the pharmacist who's in clinic, it's very easy because you're often located in the exact same area. So that communication is usually the easier of them. I think in terms of communication with pharmacies, personally, I always found email or portal usage was helpful because frankly, a lot of us just don't have time to sit. I was joking about the endless phone trees, but the truth is like we really don't have time to sit on the phone. So those have been the most efficient strategies that I've used.
Okay, thank you. We have a question for Robin. What are your thoughts on the cost versus benefit of PGX currently? If patients are needing to pay for the testing, is the clinical impact worth it?
Yeah, I think that's a great question. As we are kind of moving into an era where pharmacogenomic testing is becoming kind of a bigger question of what is the utility, I think this study showed us that kind of one of the important things with our CF population is that we know that we are already going to be getting genetic testing on them at baseline to see their CFTR mutations. So this is a great population to potentially get pharmacogenomic testing since we know we are going to be doing it and that we know throughout their lifetime they're going to be exposed to multiple different types of medications and classes. However, I think in current state, you do have to think on the individual patient level in the out-of-pocket costs. I think ideally the answer would be yes, we would do this on everyone, but I think we know that there are more barriers and limitations on an individual level we need to think about. So my answer to that would be this would be something I think is worth pursuing when the cost is reasonable for the patient. So potentially, one of the things we talked about was this is maybe not the best thing to do in January before you've hit your deductible, but something that you could potentially try to continuously pursue and wait until you do get insurance approval to try to get testing, knowing that this information will be constant throughout the individual's lifespan. However, I do think that with some of the out-of-pocket costs ranging from $500 to $1,000, that may not be reasonable at current state. But hopefully, as we move forward and learn more about pharmacogenomic testing, we will see an expansion in insurance approval. Hopefully, this is something that becomes routine and covered for all patients.
And Robin, while you're at the mic, I have a follow-up question for you as well. In your study, you found that like the most actionable medication was PPIs. So my question for you is, knowing that ETI is primarily metabolized by the CYP3A4, CYP3A5, like what's the data on the percent of people with CF that actually have abnormal metabolism with that specific genotype as far as pharmacogenomics being relevant for CFTR modulators?
I would definitely have to look back at the individual information. I think what we did find was because we took CFTR modulators out of the medications that we looked at, just knowing that all patients would be on them and kind of knowing that information at baseline, that the information that we did have with the medications that were impacted were mostly in that 2D6 and 2C19 era. So that's mainly what we focused in on. I think it would be interesting to kind of move forward and look at that data. Again, the other question too was whether we were going to start proactively taking this information or reactively. And I think just in current state, the answer is just informative. So seeing how the patient responds, again, we know that there may be a mismatch in pharmacogenomics and the medications they're taking, but the patient may clinically be doing very well. So I think you kind of have to take multiple things into account, but definitely something I'd be interested to see as we learn more.
Thank you, Paul.
Yeah, I have a question about the PBK guided dosing in the children and infants. That's excellent work. It's filling an unmet need in terms of off-label use in that population. My question has to do with, do you have outcome measures on the PBK guided dosing? Sweat chlorides, LFTs, how did they do on those dosing?
You say LFT, sorry?
Liver function tests?
Liver function, okay.
And then sweat chloride, responses.
For the PBPK modeling, we mainly focus on try to mimic adult drug exposure. We also have a look, I don't show it, on the EC50 concentration, efficacy concentration. After not really for the liver test function. Sorry.
Okay, and this is a question that perhaps you and Sylvia and Sally could speak to regarding ETI like monitoring and dosing. How would you look at sweat testing, and would you recommend that be done along with levels and yeah?
Yeah, I think if it could be done, it's the best to have the sweat test, the sweat test at the same moment of PK measurement, and if possible before ETI initiation and with a follow-up. Even for the few children, infants, we have treated, we have seen the sweat test improvement.
Have you used that to help guide? Like assess them?
It could be. In fact, we start with mid-dose recommendation that I show.
Okay.
Half. Well, yes, and we make close therapeutic drug monitoring, like 5 days after initiation, like 2 weeks after, I will say, and if the drug concentration are not too elevated. To the full dose, and the sweat test when we perform it.
And my take on that is, for research purposes, I think that would be great to have. Clinically, our clinic is adult, so we don't do sweat chloride testing as part of the routine clinical care. I don't know what the insurance policies or requests would be to add it as part of like their clinical care. So I think if you're planning a study and you want to have it, I think it's a great idea. But clinically, I don't know if it's feasible.
I find that really interesting because in Canada, we don't have TDM easily accessible. So actually, we do sweat chlorides all the time.
Okay, well, thank you so much for joining us for this pharmacy workshop, and that completes our session.